Today's topic is endodontic emergencies. The word emergency literally means any condition which warrants immediate attention. Medically, any condition, usually of unforeseen and unscheduled occurrence, requiring immediate diagnosis and treatment, is termed as an emergency. An endodontic emergency is defined as an unscheduled visit associated with pain or swelling, ensuing pulpo-periapical pathosis, requiring immediate diagnosis and treatment. So the most common dental emergency usually involves pain and or swelling, and it also may be associated with fracture and loss of tooth. Now, what are the causative factors which are responsible for the endodontic emergency? So whenever there is a pain or a swelling, it is understood that there will be irritants which induce inflammation. And whenever there is inflammation, there is release of certain chemical substances, certain inflammatory mediators like the cytokines, prostaglandin, etc. And the substance that cause pain could be of two types. It could either cause pain directly by lowering the response threshold of the sensory nerves or by increasing the vascular permeability and producing edema. So if there is pain, it usually means that the response of the sensory nerves to pain is reduced. And if there is edema and swelling, that means that inflammation has caused increased vascular permeability. It has to be remembered that along with management of the clinical situation, psychological management is also very important. This involves controlling of the situation, gaining confidence of the patient, providing attention and sympathy, or rather empathy to the patient, and treating the patient as an important individual. If we are able to give psychological comfort to the patient, that will help control the situation better. Along with this, the management of endodontic emergencies involves the following steps. That is, initially when the patient walks into the clinic, we must have a proper attitude. That is a proper empathetic attitude and a confident attitude without showing any signs of panic. One must be able to make an accurate diagnosis, understanding what to prioritize first, and at the same time not overlooking any adjuvant situation that may be present along with the main clinical problem. This also involves providing profound anesthesia so that the patient is comfortable, and the treatment that is rendered must be prompt and effective. Now, how do we classify endodontic emergencies? Endodontic emergencies could be classified as pre-treatment emergency. There could be certain emergencies that could arise during the treatment, and there could also be certain post-treatment emergencies, which could be a very embarrassing situation for the clinician. Now, what are some of the pre-treatment emergencies? The pre-treatment emergencies, one very common occurrence is dentinal hypersensitivity, which must be differentiated from acute reversible pulpitis. Then another emergency that one might encounter is acute irreversible pulpitis. Acute apical periodontitis is another pre-treatment emergency. Acute periradicular abscess, cracked tooth syndrome, tooth fracture, luxation injuries, or avulsion, all of these include the pre-treatment emergencies. So all the pulpal and periapical pathosis, along with the traumatic injuries, all of these may be a part of the pre-treatment emergency. Now, what are the mid-treatment emergencies? The mid-treatment emergencies will include pain that is happening after we have initiated the treatment. It could be due to incomplete pulpal tissue removal, or it could be due to apical periodontitis due to over-instrumentation, pushing of debris beyond the apical constriction, or pushing of the chemicals, importantly sodium hypochlorite, beyond the apical constriction. Another mid-treatment emergency is a phoenix abscess, which is an acute exacerbation of a chronic lesion. The post-treatment emergencies would include the over-obturation or sealer extrusion. It could be underfilling. It could be high restoration. It could be root fracture, missed canal, or poor coronal seal. So if we have either over-obturated, underfilled, if we have not done the post-endodontic restoration properly or have left it high, or if during obturation, the forces involved during obturation, especially lateral condensation, if it is too high, there could be a possibility of root fracture. The first pre-endodontic emergency is hypersensitive dentine. It is characterized by a sharp, short pain arising from exposed dentine in response to a stimuli, which could either be thermal, osmotic, or chemical, and which cannot be ascribed to any other form of dental defect or pathology. So here it must be understood that it is not the same of acute pulpitis. Here, this kind of sharp shooting pain is mainly due to thermal, tactile, osmotic, or chemical insult, which is happening because of the exposed dentine and not because of any direct effect on the pulp. When could you see a case of hypersensitive dentine? The most common situations are abfraction lesions, tooth abrasion, tooth erosion, and after periodontal surgery. Now, how would you treat a case of hypersensitive dentine? There could be various ways. The most preliminary treatment approach would be to use desensitizers, which may include potassium nitrate or silver nitrate, strontium chloride, or it could be your sodium monofluorophosphate, though the fluorides can be taken as a separate topic. So these desensitizers, they will occlude the dentinal tubules. These will include potassium nitrate, silver nitrate, strontium chloride, oxalate crystals, glutaraldehyde, bioactive glass, or aluminum lactate. It should be rather aluminum silicate. There could be lasers that could be used to treat hypersensitive dentine. Now, these lasers could include helium neon laser, then it could be gallium, aluminum laser, it could be carbon dioxide laser, it could be ND-YAG or erbium-YAG laser. Certain fluorides could also be used for the treatment of hypersensitive dentine, which include sodium fluoride, stannous fluoride, or sodium monofluorophosphate. The other treatments, if there is a major exposure of the dentine, would require a restorative treatment with a protective layer of glass ionomer or some other dentine protecting restorative material. And if nothing works, the final treatment would be to go for an endodontic treatment. Now, the recent advancements include a Biomin, which is a fluorocalcium phosphosilicate, Novamin, which is a calcium sodium phosphosilicate, and strontium chloride hexahydrate. Other than this, products like Recaldent, which involves CPP-ACP, that is casein phosphopeptide, and acidic CPP-ACP, that is acidic. And just get back to the name. So CPP is casein phosphopeptide, and ACP is acidic calcium phosphate. So what is acute reversible pulp? Now, another situation which causes an immediate action, which needs an immediate action, is acute reversible pulpitis other than dentinal hypersensitivity. Now, what is this acute reversible pulpitis? It is a mild to moderate inflammatory condition of the pulp caused by noxious stimuli, in which the pulp is capable of returning to the uninflamed state following stimuli of the removal of the stimuli. So it is a mildly moderate inflammatory condition of the pulp which will not require root canal treatment, but will merely require removal of the situation which is causing this exaggerated response. Then there could be another emergency, that is acute irreversible pulpitis. Acute irreversible pulpitis is an inflammatory condition of the pulp which is symptomatic or non-symptomatic in nature, with the pulp becoming incapable of healing. In case of deep caries or a fracture, the pulp may be irreversibly damaged, and there could be partial necrosis, in which case there may not be pain, or it is usually associated with a very chronic pain which is very disturbing to the patient. And sometimes the pain could be intermittent, in which case there could be periods of chronic pain, and there could be certain quiet periods when the patient is not experiencing any pain. Now, if the infection has spread from beyond the pulp to the periapical tissue, then there is a situation called as acute apical periodontitis, which is an inflammatory, painful inflammation of the periodontium as a result of trauma, irritation, or infection through the root canal, whether the pulp is vital or non-vital, producing clinical symptoms including painful response to biting and percussion. Now, interestingly here, acute apical periodontitis could also be associated with vital pulp. Suppose you've done an amalgam or any restoration which is high when the patient is occluding. So that will also cause inflammation in the apical periodontal ligament fibers. Here, once you correct the occlusion and maybe give us a painkiller for a day or two, then the situation comes back to normal. However, if apical periodontitis is caused as a progression of the infection from irreversible pulpitis through the root canal into the periapical tissue, this situation will warrant a root canal treatment. So acute apical periodontitis could be associated with vital or a non-vital treatment. Another emergency, acute alveolar abscess. It is an inflammatory reaction to the pulpal infection and necrosis of the pulp, which has led to a rapid onset of spontaneous pain. And there is tenderness of the tooth to pressure, there is pus formation, and eventually there will be a swelling of the associated structures. So the first situation was irreversible pulpitis. When the infection is moved beyond the confines of the pulp, initially there will be inflammation of the apical periodontal ligament fibers, that is apical periodontitis. If further untreated, this will lead to spontaneous pain and swelling with formation of pus in the periradicular region, leading to extrusion of the tooth in the socket, unable to close the teeth comfortably, swelling of the associated structures, and of course, pain. Now, there are certain symptoms associated with acute apical abscess, which could be, certain symptoms would be local symptoms, certain symptoms could be systemic symptoms. This is a very agonizing situation for the patient. In case of acute periapical abscess, the tooth is tender on percussion. There is a very severe throbbing pain in the tooth as well as the overlying tissues. Sometimes there could be an associated swelling. Gradually, the swelling may become very extensive. This is a situation which must be really taken seriously by the clinician, because if left unattended, this infection may spread through the facial planes and lead to cellulitis And when facial symmetry is disturbed, and if the infection is very severe, it could also be associated with fever or malaise. If unattended, it could also lead to infection of the various spaces, including the submandibular area, the submental area, and finally this may lead to Ludwig's angina, which could be a life-threatening condition. Now, how would you treat a case? As an emergency, the first option would be to try and relieve the situation as fast as possible. So surgical method is opted when all other methods have failed. So how would you do? What would you do? You would do an incision and drainage to prevent the spread of infection. This will allow release of pressure. This will lead to decrease in the number of bacteria, will help in improving the circulation in that area, will change the oxidation reduction potential, and will accelerate healing. Now here, if we see this image, this is the swelling. So you will try and incise in the most dependent part of the swelling, give a nick with your scalpel. You can enter it with a hemostatic forceps and then open it in that area and leave behind a drain, which could be a gauze, or it could be a piece of rubber dam, or it could be a surgical drain, which will allow continuous drainage to occur. So this incision and drainage will provide an immediate improvement of the situation because the pressure is released, there is decrease in pain, there is decrease in bacteria, there's improvement in circulation, there is alteration of the oxidation reduction potential. And initially the swelling, the pus that will be draining will be white and thick purulent discharge, and gradually it will become more blood-like, and gradually it will be a serous discharge. Now, Gutman described various modalities of treatment for localized diffuse swellings associated with acute alveolar abscess. Now, if the swelling is slight and localized, then there is no need for incision and drainage. This has to be understood. Here, what is advisable is warm saline rinses in addition to the root canal therapy, because the root canal therapy, especially in mandibular teeth, may only provide certain amount of drainage against the gravity. Once you allow the patient to do warm saline rinses, that will gradually thin the consistency of the pus and will allow a better drainage. Now, if the swelling is soft, extensive, and fluctuant, then you will have to do an incision and drainage as described earlier. But here you need a definite swelling to perform an incision and drainage. But if the swelling is very diffuse, where there is generalized edema and cellulitis, then antibiotic coverage and aggressive removal of any necrotic tissue in the pulp canal system is necessary. So once the swelling is evident, an antibiotic coverage should definitely be given. And if the tissue swelling is non-fluctuant, then we must give antibiotics. At the same time, give hot saline rinses so that the swelling becomes softened, so that there's easy drainage. And sometimes not performing incision drainage and not doing a root canal and simply giving antibiotics may lead to a situation of a hardened swelling, which is called as antibioma, which may be a challenge to treat. Now, an acute, here we must understand that an acute alveolar abscess must be differentiated from an acute periodontal abscess. Now, how do we differentiate that? An acute periodontal abscess, as we can see in this image, it will usually be associated with a deep pocket. And as we can see here, the marginal gingiva or the papilla is involved. Now, if there is an acute periapical abscess, then the swelling will be more apically in the middle of the apical third. An acute periodontal abscess, usually the pain is not so severe and the tooth is tender to horizontal percussion, in contrast to an acute periapical abscess when the tooth is tender on vertical percussion. So whenever there's a swelling like this, you have to be able to differentiate between an acute apical and an acute periodontal abscess. So as I've already mentioned, you can see that in a periodontal abscess in the first image, there is a tooth is vital. There is no caries. There is usually a pocket. If you take a radiograph, the radiolucency will be a lateral radiolucency. There may be a mobility in the tooth. The percussion sensitivity may be variable. Usually it will be sensitive to vertical percussion. And if there is a sinus tract present, and if you trace the sinus tract, it will be parallel to the root. It will definitely not project itself to the apex. On the contrary, in a periapical abscess, the swelling is more apically placed. The tooth is non-vital. Usually it is associated with a caries or a fractured tooth. The location of the swelling is not at the laterally, but at the apex of the tooth. The tooth is percussion sensitive. It will be sensitive to vertical percussion, and the sinus tract, if traced, will point towards the root apex. So there is not much of a confusion if you do your diagnosis meticulously. Another pre-treatment emergency is a hot tooth. Now, a hot tooth is a tooth which is very difficult to anesthetize. After you achieved anesthesia of the tongue or the labial tissues and all other symptom anesthesia are obtained, the tooth may be still difficult to anesthetize. It's still difficult to open if it is a hot tooth. In such a case, it is due to certain tetrodotoxins that are present, which are responsible for a hot tooth, which are resistant to the effect of anesthesia. There's a disturbance in the sodium channel when there is a hot tooth, and therefore the electrical potential of the sodium channels is altered because of this tetrodotoxin present, and the tooth is difficult to anesthetize. Here, a supplemental intraligamentary anesthesia or an intraosseous injection have found to be to provide more profound anesthesia. So we have mentioned here that all the pre-treatment emergencies are usually associated with either pulpo-periapical pathosis or it is associated with dental trauma. So the first trauma could be a cracked tooth syndrome. Various cracks where there could be only a fractured cusp, which can be reasonably treated. There could be a fractured tooth not going subgingival. Once the fracture line goes subgingival, we have already studied in depth, the treatment becomes more and more difficult. It is important that the fracture line be brought supragingivally to be effectively treated. And if there's a split tooth like this, definitely the tooth is non-salvageable. How would you test a cracked tooth? Ask the patient to bite on the tooth's root. When the patient will normally say that otherwise my tooth is not painful, but when I bite on the tooth is very painful. Then there could be a crack line where the tooth is stained, and once you remove the stain, the wash of the stain like methylene blue, the crack retains a stain. Magnification is very helpful in such a situation. We have already studied in depth about the traumatic injuries. We have understood the various fractures. Now, if there is a displacement of the tooth, there could be various situations. We have already studied this. There could be a situation where there is a displacement, or there could be no displacement. So if there is no displacement, there could be a situation where the tooth is loosened slightly. That is a situation that is subluxation. That is, the tooth is slightly loosened but not moved from the position. There is some tearing of the periodontal apical ligament fibers. Or there could be no loosening, but there could be a trauma wherein there could be a slight fracture of the tooth, but otherwise, but the fracture, if supracrestal, easy to treat. If it is going subgingival, it becomes difficult to treat. And there could be a situation where there is displacement of the tooth. where there is displacement of the tooth. Of course, when there's no displacement, concussion is another situation where there is just some disturbance to the periodontal ligament fibers without any actual trauma to the tooth per se. Then where there is displacement, there could be mobility or there could be no mobility. There could be no mobility, yet the tooth could be intruded in the socket. If the root formation is not complete, allow it to extrude to its original position on its own, which usually happens within a period of 7 to 10 days. Or there could be a situation where there could be a lateral luxation. The tooth is usually, the root is locked buccally and the crown is pushed palatally. Using digital pressure, in such situations, the tooth must be repositioned and splinted. Now, if there is mobility, there could again be various situations. There could be mobility because there is an extrusion of the tooth from the socket. There could be mobility if there is a fracture, either middle or apical third. There could be mobility if there is an alveolar fracture, or the worst situation would be also when the tooth is avulsed from the socket. Now, if there is a crown fracture, it could either be an enamel infraction, that is, there is an incomplete fracture of the enamel without loss of tooth structure. There could be micro cracks in the enamel. Usually after a pulp vitality checking, the tooth does not need much of a treatment. In case of an enamel fracture, you would of course do a vitality testing. You could either do a gingival recontour, enamel recontouring like this, or if it is more, you might need to restore it with composite. There could be a situation of enamel dentine fracture without pulp exposure. Do a composite restoration after pulp protection, or laminate, whichever works, or a fracture fragment reattachment. And there could be a situation where there is, here we can see this image where it has been etched, bonded, and a composite restoration done, polished and finished nicely. You could also restore it using a putty index, where you take the impression with putty, pour a model, build it in wax, make a putty index, place a putty index palatal to the tooth, then use flowable composite to build the palatal shelf, over which build with dentine and the enamel, and the tooth can be restored beautifully and unidentifiably. So it could be as good as this with a composite buildup. Then there could be a situation when there is an enamel and dentine fracture with pulp exposure. Here, you have to understand how fresh the exposure is. If it is a fresh exposure, you could try pulp capping. Better still, with better results, you could do a pulpotomy, leaving the radicular pulp intact, just removing the coronal pulp. And if nothing works, proper pulp extirpation and root canal therapy would be the option. So as I mentioned, you could do a pulp capping, pulpotomy, or root canal treatment followed by post and core. If the patient comes with a fractured fragment, you could also reattach the fractured fragment. If the root apex is incompletely formed, regenerative endodontic therapy or apexification also must be considered. Sometimes if you want to do a post and core, it could be either a metal post or a fiber post. And nowadays you have these customized fiber posts where the tooth is, suppose the inclination of the tooth is not proper. So rather than placing a stiff fiber post, you could also place a post which is pliable, which is adjusted to the tooth and to the direction that you want to, so that you could improve the contour of the tooth. And then once cured, it retains stiffness, and over that you could do your core buildup. Fracture reattachment. Here you can see the fractured fragment. It is kept. Root canal treatment is done. A post is placed. The coronal fragment is adjusted to retain the post in this area, and the fragment is reattached. You could also attach the post after root canal treatment to the coronal fragment, and you could re-cement the coronal fragment with the post into the root. More complicated still, we have the crown root fractures, which could be at any level. Once the root is involved, the the prognosis is usually compromised. It could just involve removal of the fragment. It is important to bring the fracture line from the subgingival area to supragingival area to have a favorable prognosis, which could either be done with gingivectomy, sometimes osteotomy, and it could also require orthodontic extrusion or surgical extrusion. This is a case where gingivectomy is done and osteotomy may be successfully done, especially in the not so visible palatal areas. Forced orthodontic extrusion is another option where a bracket is placed and with elastics, you could bring out the tooth to a more supragingival area, hold it in place for bone formation to occur apically. This is a situation where post has been temporarily attached to the root and it is with wire and composite. It is attached, and as we with time the tooth can be brought out supragingivally with forced ortho. This will require the help of an orthodontist. Another option would be to do a forced surgical extrusion of the tooth, where gently with the help of forceps tease the tooth out of its original position, splint it for a period of 2 weeks and allow bone formation to occur apically to stabilize the tooth. As we can see here, the tooth was very equigingival. It has been brought out subgingivally, sutured in its new position, and how beautifully the gingiva has healed, and you can place a crown following that. Root fractures is another pre-endodontic emergency, which may be at the coronal third, middle or apical third. As we have already discussed in the chapter of traumatic injuries, the apical root third fractures generally have a better prognosis than the cervical fractures. So coronal, middle and apical. Coronal fractures are less favorable due to difficulty in immobilization. Splints for stabilization after 4 months are required, and this is an area which is maximum prone to contamination. Middle third fractures, it has better prognosis because here you are doing a root canal, may be done of both the segments. It can also be done of the coronal segment, leaving the apical segment undisturbed, and RCT can be done without of the coronal segment and removal of the apical segment in case you get to see periapical lesions gradually, and you could also do an intra-radicular splinting, which was very popular previously but not so popular anymore because chances of apical leakage led to ultimate failure. Apical third fracture, the prognosis is favorable provided the tooth is immobilized. For all these root fractures, immobilization is very important because prognosis is favorable provided that the tooth is immobilized and not under any force of mastication. That is, the occlusion has to be properly relieved and the tooth has to be stabilized. Otherwise, the tooth, if mobile, the prognosis will not be favorable. Then we have the luxation injuries. We have discussed them before. I revised them again. Concussion. Concussion involves injury to the supporting tooth structure without abnormal loosening or displacement of the tooth, but with significant reaction to percussion. Here, occlusal readjustment is required and periodic vitality testing is required to see whether the tooth is becoming non-vital over a period of time. Then there's a situation that is subluxation, where there is injury to the supporting tooth with resulting in abnormal loosening without any displacement. So what we have to do is we have to reposition the tooth and splint it. Then there is a situation where there is extrusive luxation, where there is peripheral displacement or partial avulsion, and injury involving displacement in the coronal direction. We see that the tooth is extruded from the socket. There will be slight bleeding from the gingival sulcus. You have to position the tooth back in the socket and splint it. Lateral luxation, this is more disturbing, involves displacement labially, lingually, or distally or incisally. Here there is rupture of the periodontal ligament pulp as well as injury to the labial or the palatal alveolar bone plate. So now, usually what is seen here is that the crown is displaced palatally and the root is locked labially. So using a digital pressure, the thumb on the palatal side and the index finger in the apical cortical bone area, the tooth is repositioned and splinted. Intrusive luxation and injury involving displacement in the apical direction and axial impact usually causes this. Teeth with incomplete root formation, there's spontaneous re-eruption. And if there doesn't occur, then re-eruption is the treatment of choice, or else you have to do orthodontic repositioning. If there is complete root formation, endodontic treatment is required. Now, a situation where there is exarticulation or avulsion. Here, there is complete displacement of the tooth out of the socket. The healing will usually occur by ankylosis. The tooth should be immediately cleaned and replaced in the socket. The storage medium preferred are either saline or milk or Hank's balanced salt solution or via span, any of these. And depending upon the stage of root development, the treatment will vary. And now, if there could be two situations when there's an open apex or closed apex, and if the extraoral time is less than 60 minutes and the extraoral time is more than 60 minutes. So if the root is completely formed and the extraoral time is less than 60 minutes, then pulp extirpation, you place the tooth, splint it. Pulp extirpation may be done within 10 to 14 days after reimplantation with long-term calcium hydroxide dressing, ranging up to 2 weeks to 6 months to prevent any resorption. And if the extraoral time is more than 60 minutes, then, and here, if it was less than 60 minutes, treat the root with doxycycline. If it's more than 60 minutes, you could treat the root with fluoride to prevent resorption, because you do not expect the periodontal ligament fibers to remain viable, but place long-term calcium hydroxide dressing to evaluate the rate of replacement resorption before obturation. Now, if the extraoral time is less than 60 minutes in an incompletely developed root, then the first choice would be to replant immediately and allow revascularization. Endodontic treatment is contraindicated as a first treatment of choice, but if gradually you see pulp necrosis occurring, then you could do revascularization or long-term epixification with calcium hydroxide or short-term epixification with MTA. If extraoral dry time is greater than 60 minutes, then do not reimplant the tooth. Then, now restoration. Crown restoration or sealing of endodontic access cavity is performed at the earliest, and follow-up must be done for any kind of trauma at 1 week, 2 to 3 weeks, 3 to 4 weeks, 6 to 8 weeks, 3 months, that is 3 months, 6 months, and yearly for a period of 5 years. So these were all your pre-endodontic emergencies. Now coming to the emergencies that might be encountered during endodontic treatment. There could be flare. These are usually called flare-ups by American Association of Endodontics, and acute exacerbation of a periradicular pathosis after initiation or continuation of root canal treatment. It could either be due to mechanical factors or chemical factors. Mechanical factors would involve periapical extrusion of debris, incomplete removal of the pulpal tissue, or over-instrumentation, that is working beyond the apex. Or there could be clinical factors, that is any irrigant, especially hypochlorite, being pushed beyond the, or if beyond the apical constriction, pushing of intracanal medicaments beyond constriction, like calcium hydroxide, or over-obturating the root. Why does this happen? That is, irrigants are pushed beyond the apical constriction. That is, when you place a needle and the needle is locked in the canal, and you push the irrigant, then the irrigant will flow beyond. So whenever you feel that your needle is wedging in the canal, retrieve the needle slightly and then irrigate. If calcium hydroxide is placed in the canal with a lot of pressure, that will also cause a periapical pathosis. The third factor could be bacterial factor. So mechanical factor, chemical factors and bacterial factors. The bacterial factors could be due to extrusion of microorganisms, due to disruption of balance between various microbial communities within the root canal, which will favor the overgrowth of certain species, because in the root canal, there are certain facultative anaerobes and there are some obligate anaerobes. So once you open the root canal, the obligate anaerobes in the presence of oxygen will die down, but the facultative anaerobes, which can survive in the presence as well as the absence of microorganisms, in the presence or absence of oxygen, with less competition may thrive even more. So this disruption of balance could lead to a flare-up. Also, alteration of oxidation reduction potential favors the overgrowth of facultative bacteria, and coronal leakage leads to secondary intraradicular infection. The age group that is very prone is those under 20 or above 40 to 59 years. Above 60, usually chances of flare-up is usually less because the apical constrictions becomes very short or obliterated. Females are more prone than men, and the mandibular molar are more prone than maxillary molars. Obviously, because drainage is also a problem with the mandibular molars, which is not so much a problem with the maxillary molars. So the clinical conditions that could be associated in this mid-treatment flare-ups is an acute apical periodontitis, which is because of the mechanical, chemical, or the bacterial insult. Or sometimes it could also progress to an abscess, that is a phoenix abscess, that is a recrudescence of a chronic apical periodontitis. Another emergency is a hypochlorite accident, which is a very unfortunate situation. A hypochlorite accident could occur if sometimes you mistake an LA syringe, mind you, an LA syringe and a sodium hypochlorite syringe. If you are in a hurry, you may end up injecting hypochlorite instead of anesthesia, which could be a devastating situation. So this is one clinical tip that I'm giving you. Whenever you give anesthesia, always use the lid to cover the needle of the syringe. Never leave it exposed, and all your irrigants always keep the needle bent at 90 degrees when it is placed on the tray. If that judicious awareness is lost for a moment, you are in for major trouble. So sodium hypochlorite accidents will require immediate anesthesia. You have to give anesthesia immediately. Patient will complain of severe pain, swelling. There could be immediate hematoma. So you need to give anesthesia, have to prescribe analgesics, have to prescribe antibiotics, have to prescribe corticosteroids, and in rare cases might require also a short hospitalization. Air emphysema, another devastating situation. If you end up irrigating, if your syringe has an air bubble, and if you end up irrigating into the canal with the air bubble being pushed beyond the apex, it could cause air emphysema, which could also be a life-threatening situation. Another situation is aspiration or ingestion of endodontic instruments, which is an extremely unfortunate situation. So placing a rubber dam during endodontic treatment or tying a floss during endodontic treatment should be considered seriously. Coming to post-endodontic treatment, this could be due to over-obturation with sealer, over-obturation with GP. It could be due to underfilling. It could be due to a high restoration. It could be due to a root fracture. It could also be due to a missed canal or a poor coronal seal. So if you're doing an over-obturation, that is, if your master cone selection is not proper, your GP might form a spaghetti like this, or your sealer may be extruded like this, and this may cause a foreign body reaction, not at all desirable. So your apical tug back is very important. Underfilling is, of course, not desirable. Getting to the full length, cleaning the apical constriction, obturating properly is important. Whenever you leave untreated pulp tissue, that will eventually lead to a periapical infection. If the post-endodontic restoration is high, again, there will be apical periodontitis and the patient will complain of pain. If your obturation or post placement causes unnecessary forces or if the post has a very large diameter, then there will be a root fracture. If there is a vertical root fracture, the patient will usually, if there's a horizontal root fracture, it will be visible on the X-ray. But in a vertical root fracture, you may see a J-shaped lesion or a deep pocket associated with one root, as we can see in this. Another case of post-treatment emergency is if you have left any of the canals untreated, maybe an MB2 or any extra canal which is located using a CBCT and needs to be corrected. Here the lesion is because of in the mesiobuccal root. Here there is a missed MB2 canal. Also poor coronal seal. Even the best of root canals may fail if the coronal seal is not proper. So these are all your post-endodontic emergencies. Thank you.